It's my honor now to introduce Todd Ibrahim. Todd is currently the Executive Vice President of the American Society of Nephrology. The American Society of Nephrology represents more than 21,000 kidney care professionals in 131 countries around the world. Todd is also the president of the Council of Medical Specialty Societies, which is a coalition of 43 societies representing more than 790,000 US physicians. He has written numerous articles on the nephrology workforce and on innovation in the nephrology space. He's also recently written a chapter for the Guidebook for Clerkship Directors called Understanding, Navigating, and Leveraging US Medicine. Some of his prior roles include he was the founding executive vice president of the Alliance for Academic Internal Medicine, the director of public policy for the Association of Professors of Medicine, and the director of communications for Robert Betts Associates. In addition, he was a staff assistant for US Representative Thomas C. Sawyer, a Democrat from Ohio. He has been a two-time recipient of the George Washington University Jenny McKean Moore Scholarship for Poets, and he received his bachelor's degree from the University of Maryland in College Park and his master's degree from Johns Hopkins University. Todd, I turn the stage over to you.
Great. Well, thank you, Jeff. I appreciate the introduction. And I will now try to share my screen. So I'd like to, as I mentioned, I really do want to try to go through the nexus between systemic racism and the COVID-19 pandemic and how that will accelerate trends in what we're calling kidney medicine. And there's a quote from Vladimir Lenin that I think sums up this year well, which is, there are decades when nothing happens, and there are weeks when decades happen. And if you go back to the 2 years that are the most similar to this year, 1918 and the H1N1 virus pandemic and all the social unrest in 1968, you can see that there were a lot of advances, and most of these advances, I think, resulted in positive change. In terms of the 1918 pandemic, I think a lot of what happened related to public health and governments, both local and state and federal governments, working more closely together, but also from a global perspective, more cooperation around healthcare and health delivery, as well as after 1968, a real recognition of the diversity of the United States population and at least movement towards, and we can argue the amount that was accomplished, but there was clearly movement in the right direction and sort of lasting change, and change that I think continues today, and we'll circle back to that near the end of the presentation. But I do think what happened then serves as, in these 2 years, really does serve as a good model for anticipating what's likely to happen moving forward. And what happens in these situations in years like 2020 is you have a number of accelerants. And I won't spend a lot of time on this slide, but I will give you a chance to kind of look at it, because these accelerants really are changing all aspects of our society. And I think if we step back and think about society broadly, then move to healthcare more generally, and then specifically to what this could mean for nephrology or kidney medicine, I think we can make some pretty logical predictions as to what's going to happen in the future. And just to highlight a couple here, clearly there's going to be a discussion around economic systems and social injustice, as well as we're going to think differently about how we deliver content. That content can be entertainment, that it can be food, it can be other products and services, but also we can think of it from a healthcare perspective in terms of telehealth, or specifically in the nephrology arena, issues and momentum around home dialysis. So a lot of these accelerants, I think, will just speed changes that we've been talking about for years. I thought Lillian did a wonderful job as she was describing aspects of the executive order. You can think a lot about the executive order and some of the aspects there, which I'll return, but also her slide around social determinants of health, I think also provide an opportunity in terms of how these accelerants may work. But at the same time, we have to recognize the other part of Lenin's quote, which is decades where nothing happens. And I think we have to take a step back, and I'll go from the more general to the more specific, but ultimately there's an indictment here on academic medicine broadly defined. And if you look at the US population and you think of the diversity of the US population and the fact is well documented that there's been a disproportionate number of cases of COVID-19 around affecting Black and brown people, and that you then look at what the poverty statistics are and the correlation there, and again, the disproportionality. And then you think about sort of the healthcare community and the patient population and how disproportionate the provider population. Now, I just looked at physicians because those were the data that were most readily available to me, but you can see how few physicians are either Black or Hispanic Latinx. And these are numbers that have not changed greatly for the last 40 years. And the last major effort I know of from a federal perspective was the Association of American Medical Colleges 3000 by 2000, which did try to increase the diversity among medical students. And you can see, while it may have made some progress, that progress has not been lasting. And 20 years was a long time ago. And what we're going to do, what should we do as a broad society as we think about academic medicine? And we also think about the large sort of federal investment in graduate medical education. What responsibility do we have to call for change and to demand that we do better in these areas? Just to add in, as you look at the nephrology fellows, you can see that there is a little bit more diversity, but still the initial pool is so small that there really is a problem here. I think this is an area that we need to return to again and again and again until there is progress. I thought the best summary of where we are right now was from a recent article from Ed Yong. And if you haven't been following his work in the Atlantic, he really has done a terrific job in terms of describing sort of the pandemic and putting it in a broader context. In his most recent article, the last paragraph, he makes the point that as a society, the United States has accepted and has just become used to things like poverty, racism, school shootings, police brutality, mass incarceration, sexual harassment, widespread extinctions, changing climate. And his supposition is that COVID-19 will be added to this list. You could add homelessness to this list. There's a whole set of things that we could add. And I think, again, this is a moment for us as a society to say, is this the direction we'd like to go? Or is there an opportunity to really push for lasting change? And what should that change be? And again, as Lillian said in her presentation, which I think was exactly right, what is it do we want? What's the future that we want? What are we imagining? What are we trying to describe? And so as we take a step back and we say, okay, well, what will the workforce look like? And we'll start broadly and we'll move more specifically to kidney medicine, is as you think about the workforce in 2030, so just at the end of this decade, and the four generations that will be working will be the sort of end of the baby boomers that are still in the workforce, Generation X, the millennials, and Generation Z. And what we know is that as these generations move from the baby boomers to Generation Z, they become much more diverse. They become much more interested in issues around diversity, equity, and inclusion. They grow up with a very different understanding of the world around them and what they want the world around them to look like. And I think most importantly, and this is something that's just starting to be identified by the demographic experts, is that Generation Z, when you think about what's happened over their lifetimes between 1997 and 2012, they're most going to resemble the baby boomers. And so in my own shorthand, and I know this is a bit glib, I sort of think about them as perhaps baby boomer 2.0. And so as we think back to what strategies worked with baby boomers, what was appealing to them, what their values were, what they cared most about, I think there's an opportunity to really engage Generation Z, who will be coming sort of to the forefront of the workforce by the end of this decade, but also then to engage the millennials, Generation X, and that group of baby boomers. And I think just to hit this point a little more firmly, there's recent data that was generated this summer of a survey of Americans, and it'll be released later this month or early next month, just talks about what do we value after sort of the event. So again, this was work that was done in July, so coming on the heels of both the COVID-19 pandemic and all the discussions around systemic racism. And what they found was people most value at this moment in time kindness, honesty, and optimism. And I think that's an opportunity, and I think that's really something to get excited about. But also, I think there's a point in here that when you think about the sort of American exceptionalism, if you will, what we tend to focus on usually is tenacity, ingenuity, creativity. And you can see that those values are less valued. So as you're imagining what the workforce is going to look like in the future, as you're thinking about how best to engage current trainees in the next generation, thinking more about kindness, honesty, and optimism, I think is an opportunity for nephrology as a specialty to really start to redefine itself. I won't spend a lot of time on the relationship between COVID-19 and the kidneys, but I think what's important is that A, it's had a disproportionate impact on people with kidney diseases, kidney transplants, and kidney failure, as well as it's resulted in a number of individuals, a number of Americans and other people across the planet who have now kidney diseases. They either had acute kidney injury or they're going to have a more chronic kidney issue. And so it's raised the profile of kidney disease to a level that it has not existed previously. And I think how we manage that and how we think about that reality will be really important as we start to define what the future of the specialty should look like. There's also been some work, and I think the most elegant sort of articulation of this is Rajiva Agrawal's article in Nephrology Dialysis Transplantation, where he talked about how every aspect of COVID-19 interacted with nephrology. It could be new collaborations, innovation, telemedicine, which I mentioned earlier, virtual learning, social determinants of health, which Lillian described very well. There's just a lot of intersections here, and we have this huge opportunity to think about how we transform the specialty around all these different areas and this accelerant, if you will, of the pandemic. At the same time, we're uniquely positioned in terms of where nephrology, where people with kidney diseases fit related to systemic racism. And in June, ASN had the opportunity to testify at a House Ways and Means committee looking at these issues and sort of the nexus between kidney diseases and COVID-19. And no matter which metric you use, there's an issue here that Black Americans and Mexican Americans are more likely to have kidney disease. They're more likely to progress to kidney failure. They're less likely to be identified for transplants. They're less likely to be listed as living donors. They're going to be less likely to be placed on waiting lists. They're going to receive lower quality kidneys, and they're going to have poorer graft survival, and they're going to be less likely to be recommended for home dialysis. So any metric you use, Black and brown people receive poor care and have poor outcomes in the United States related to kidney disease. I think this, again, is something we have to take responsibility for acknowledging and then committing to do everything we can to address this reality. The Ways and Means Committee didn't stop with a hearing. Earlier this month, they reached out to a number of organizations, including ASN, and they said, we have real concerns about the level of racism in medicine. And specifically, we'd like to ask ASN to do two things. First, could you just walk us through why race is included in the calculation for EGFR? And second, what are you doing as an organization to respond? So to that first question, we had in August formed a joint task force with the National Kidney Foundation, and you have listed here the members of that task force to look at that calculation, to have the conversation around the fact that race is a social construct and not a biological one, and how do we account for biological realities in GFR without including race, and what does that look like, and what the true challenge that we have there. That group has started to meet regularly. We have long sort of sessions where we're bringing in outside experts to testify, and I have to say it's been fascinating as we've dug in, because I think there's a real opportunity here, and a lot of these questions are being driven by medical students and medical residents who have real questions about what they think medicine should look like. And there's an opportunity for us, if we work together, if we really do try to follow the data and the expertise, to identify better ways of identifying people at risk for kidney disease, at risk for kidney failure. At the same time, besides that specific issue, the committee did want to know sort of what the plan was. And so what we've talked about organizationally is we need to take a step back. And as I've mentioned in a couple of different places in this presentation, we need to focus more on the overall health of the entire population. That needs to be the starting point. And at the same time, we really do need to think about policies that will address health disparities and social determinants of health. And we also have an opportunity, because we're a publisher, because we have a number of communication channels, where we can use those to acknowledge and confront high profile acts of racism, and really try to use the microphone that the organization has within the community and more broadly among other medical specialty societies and the rest of sort of organized medicine. But then finally, and this goes back to the slide about how few medical students are African American or Hispanic Latino, is we really do need to acknowledge that there are acts of racism, and we need to commit to dismantling those, particularly in academic medicine across the tripartite mission of care, research, and education, including training, as well as administration. The sort of broader setting that we find ourselves in, the different aspects in terms of ASN, its foundation, Kidney Cure, its efforts related to advancing excellence in patient care, the Kidney Health Initiative, which is a partnership with the FDA, and Kidney X, which is a partnership with the Department of Health and Human Services. And then finally, again, the community of the kidney community, and then the broader community, or the sort of ecosystem that we find ourselves in. There's an opportunity here, but the first step is to acknowledge that there's an issue, that we need to confront it, and we need to confront it across the organization. It has to be an effort that's part of the entire operation and every aspect of what we do. Just to sort of transition a little bit to the broader community, as Jeff mentioned in his introduction, for this year, and my term's about to end, I'm the president of something called the Council of Medical Specialty Societies. And CMSS is a number of medical specialty societies, and you have all their logos, and together they represent about 800,000 physicians. Many of the organizations, like ASN, also have other health professionals as members, but the sort of core initial membership of CMSS is the physician, the US physician. And we have an opportunity here, both in terms of our statement against racism in healthcare, but also my successor will be Darylyn Moyer, who's the CEO of the American College of Physicians. And the number one issue for CMSS for next year will be looking at ways the societies can work together to address systemic racism in healthcare. The current federal policy, as a result of the executive order in years before that of efforts by our entire community, is related to shifting from rewarding sort of or paying for kidney illness to promoting kidney health. And the way I would describe the executive order is it has 5 components. These are the components of the broader federal policy: raising awareness about kidney diseases, slowing progression of kidney diseases, improving treatment options currently, increasing access to kidney transplants, and promoting research, discovery, and innovation. And again, sort of accelerated by the announcement last year, but then moving forward since then and building on previous progress, we're making significant progress as a community in all these areas, from awareness campaigns that are targeting consumers in our community and the investment community, all sorts of new therapies related to the early, the causes of kidney disease and trying to identify people early and treat them, SGLT2 inhibitors being the most recent example, but a lot of other exciting science that's happening. Everything that's happening with telemedicine, the coming final rule related to the ETC, the mandatory model, as well as the voluntary models. A whole number of activities related to kidney transplants. Again, a final rule around organ procurement organizations coming soon. And then finally, as I've mentioned, the Kidney Health Initiative and Kidney X. There's just a lot happening, and it's starting to align in a way, and the community's aligning around it in a way that I think is really exciting, and we have a unique opportunity here. And so just to highlight, the National Kidney Foundation is responsible for working with HHS on a campaign that's raising awareness around kidney diseases. It's targeting the RU33%, so saying if you're at risk for kidney disease, if you have cardiovascular disease, hypertension, diabetes, genetic predisposition, you're part of that 33%, and really trying to use that as a way for people to get themselves tested, to start to interact with their primary care physicians, and if they do have kidney disease, with their nephrologists. So as we think about 2030, there are at least 3 imperatives. And the way I would describe them is prevention, inflection point for kidney health. It's urgent for us to act now. We're working together to shape the future around people with kidney diseases, kidney failure, and kidney transplant, as well as the millions of people who are at risk for kidney diseases. We are a community, and together we're proud of our work, and we're ready to tackle the toughest challenges in healthcare and in society. And we offer the one thing that today is in short supply, and that's hope. So I'll stop there and thank you for the invitation to speak. And I look forward to the discussion on the panel.